chronic myeloid leukemia. As we understand that there is the clonal proliferation of these hematopoietic cells which has more propensity towards the differentiation into granulocytic lineage and to some extent towards the platelet lineage. Okay. So, why it happens? The most important is there is chimeric protein which is formed in this setting, which is nothing but BCR-ABL, which is a 210 kilodalton protein, and this results in constitutive activation of tyrosine kinase pathway, resulting in excessive proliferation as well as differentiation into granulocytic lineage in case of chronic myeloid leukemia. This is usually seen in elderly individuals after the age of 50 years, and it is indolent and slowly progressive in nature. As I already told you, the genetics play a very important role here. It is the reciprocal translocation involving chromosome 9 and 22 where they have ABL and BCR, and finally it results in a fusion protein which has got the constitutive tyrosine kinase activity. Moving on to peripheral smear and bone marrow examination findings. So, when you look at the peripheral smear, of course, the findings differ whether you are seeing the patient's peripheral smear in the chronic stage, accelerated stage or blast crisis. In general, what you expect here is there is proliferation of the myeloid precursor cells as well as some differentiating cells. So, what are the cells which come under that lineage? So, if you remember cells starting from myeloblast, then we have promyelocyte, myelocyte, metamyelocyte, band forms and neutrophils. Right, you will see all those cells, but the blast count, okay, will be usually less than or equal to 10% in case of chronic phase, and it is during this phase if you do a lab score or leukocyte alkaline phosphatase score, it will be low. Very, very important in case of leukemioid reaction, because this is one of the important differential diagnosis, that is leukemioid reaction, right? You are seeing blast, that is one point, and the second thing is if you do a lab score which will be high in case of myeloid leukemioid reaction, whereas in case of chronic phase of CML it will be low. Okay, very important. Which is the other condition where you expect lab score or NAP score to be low is paroxysmal nocturnal hemoglobinuria. This is also one of the important MCQs. Now, continuing with the morphology, as I already told you, you will see the family of cells which belong to this myeloblastic lineage. So, let us try to identify them in this peripheral smear. You can see that these are the myelocytes. They have got some granules in them, but the nuclear segmentation has not yet started. Okay. Here we have something called as the metamyelocytes, where you have the beginning of this indentation. This also is a metamyelocyte, and then we can see band forms, and these are the mature neutrophil forms that we can see, right. We also have some promyelocytes. So, these are the different lineage cells. This is some eosinophil precursor. You can see that some orange cytoplasm is present, and also we have got some nucleated RBCs within the peripheral smear. So, in WBCs, apart from those cells which belong to myeloid family, we also have got increased granulocytes in general, that is basophils. It is a very, very important cell. Remember this. Basophil, then varying number of eosinophils. They are in general increased in number, and as the patient moves towards the accelerated and blast crisis, the number of basophils are usually increased. Okay, they can range up to or more than 20% basophils can be present in such cases. Remember this. This is a pointer, one of the important diagnostic pointer in case of chronic myelogenous leukemia. So, this is about WBC. Count is enormously increased, and this is the cell population that you see, and blast count is in chronic phase is usually less than or equal to 10%. Whereas in case of accelerated phase, you expect between 10 to 19% of blast count. And once you reach the blast crisis phase, it looks like any other acute leukemia, that is acute myelogenous or acute lymphoid leukemia. With respect to platelets, you need to remember one morphology. Usually platelets are increased in case of chronic phase. You will see thrombocytosis, okay, and morphologically you will see lot of giant platelets. But again, once the patient enters into blast crisis, there will be thrombocytopenia, very important pointer. Right. Now, after you examine a peripheral smear, parallelly you will examine bone marrow. So, what do you expect in bone marrow? So, the granulocytic precursors, they are increased, and also the maturing forms are also increased, like basophils, neutrophils, promyelocytes. All those cells are increased in number. Apart from this, you will see a specialized cell which is called as a C blue histiocyte. This particular cell has a wrinkled tissue paper like bluish cytoplasm, okay, which is present within the histiocyte. This is also one of the features of chronic myeloid leukemia. With respect to megakaryocytes in the bone marrow, you will see hypolobated forms of megakaryocytes, and there can be some varying degree of reticulin fiber deposition in case of CML. If there is blast crisis, you will see that the blasts, that is lymphoblasts or myeloblasts, are present or packing the bone marrow, and they are suppressing the normal hematopoiesis. So, moving on to cytochemistry and ancillary test in case of chronic myelogenous leukemia. As I told, in chronic phase, remember this very, very important, neutrophil alkaline phosphatase score. What happens to that? It will be low. Very, very important. The serum B12 levels are 10 times the normal. Why is it so? Because the transcobalamin 1 and 2, which is present within the neutrophils, now you have lot of neutrophils present, and that results in increased B12. LDH is increased, and even the uric acid levels are increased, indicating the increased proliferation levels, right? So, this is about the cytochemistry. What are the ancillary tests that are you going to perform in this setting? Very, very important. Now, you have seen a marrow. Is it sufficient to call it as a chronic myelogenous leukemia when all morphological pointers are present? The answer is you have to do an ancillary test. The diagnosis lies in the fact that you need to demonstrate the BCR-ABL chimeric protein which is present, right? So, how do you do that? You can demonstrate the reciprocal translocation present by doing a karyotyping, but sometimes you will miss the positive finding, and you need to go for the other molecular testing like fluorescent in situ hybridization or PCR, okay. So, there is a role of ancillary test in the diagnosis of chronic myelogenous leukemia.